when you talk to a mother of 3 kids that's living in her car because she doesn't have a house to sleep in tonight, and then you think about all of the things, all the buildings that need to be built to house people like her, you go, there's a big disconnect.
Jake Rothstein is the founder of PAPA, a national companionship platform for older adults that raised over $240 million, but now he's building Upside, a housing stability platform turning real estate into ROI. We're talking 97% enrollment, fewer ER visits, better participation, and more trust. It's the kind of infrastructure shift that payers, providers, and program leaders can't afford to ignore. This is the new front line of care. So if you believe that care doesn't stop at the clinic door and you're already building programs that actually move the needle, you already belong here. I'm Christina, and this is Outcomes.
What's the value proposition for housing as healthcare infrastructure?
That's a great question. There's a lot of different value propositions, and it really depends on who within a healthcare organization you're talking to. If you're talking to healthcare quality people, or if you're talking to member engagement folks, or if you're talking to population health folks, they're all a little bit different. But from our perspective, when we think about housing and housing instability, ultimately kind of at the highest level, we're thinking about reduction in medical spend. We see a very clear and present ROI with housing instability interventions and getting people, especially at the highest end of this cost spectrum, those that are most vulnerable among us, people that are Medicaid, that are dual eligible, that are maybe people in the LTSS population. We see the highest cost folks within these population types having the quickest ROIs, but across the board, we see really strong ROIs. And that's really our initial kind of starting point. Hey, we get major medical cost savings from housing interventions across population types. Let's open the discussion and let's let you know what it means for your team and your department and how it might impact you. So value propositions vary dependent upon the persona that we're talking to, but generally speaking, it's medical care cost reduction.
What do you say to the question when you get that question about value ownership?
Like in terms of how I might respond to that and who owns that value? I mean, typically we're doing a lot of discovery with the folks that we engage with to understand really what's important to them in their role. Is it quality metrics? Is it HEDIS measures? Is it star ratings? And we understand how to kind of integrate the program into existing infrastructure so that we can satisfy everyone's kind of value proposition needs.
I see. So what did that initial phase of direct-to-consumer model teach you about market fit before you approached payers with this?
Yeah, it's a great question. We started out in the direct-to-consumer space to start understanding the consumer. And we started out in the older adult space because we had a thesis around housing instability among older adults. I think historically it had been thought of as a person with disability problem or as a low income problem only. And what we said was, well, housing instability doesn't have to just be a financial issue. It could be a mobility issue. It could be a variety of different factors that cause housing instability. And so we started in a place of knowledge because we understood the older adult population. And we said, okay, if we can start understanding an older adult as it relates to their quality of their housing, the accessibility of their housing, the affordability of their housing, now we can start building models around reductions to ED visits and models around reductions to fall risk, things that really are applicable to older adults. And then we started broadening as we sort of realized in the direct-to-consumer model that housing instability was more broad than we had even thought. We said, well, a lot of the same factors that we learned in our work with older adults kind of spread the gamut, and we saw kind of similarities across different population types. And that's when we said, okay, we're going to go to payers as a distribution channel because we really understand this could be a win-win-win for all parties involved. It can be a win for the member. It could be a win for the health insurer, the health plan. It can also be a win for the federal and state government programs and dollars and the taxpayer that actually has to pay for all these medical costs. And as a result can get savings from a reduction to them.
What was the hardest thing about distribution?
I think circling back to the initial question, right? I think the hard thing about distribution in this market and selling to big payers is, number one, there's a variety of different people in these organizations that all have different incentives. So aligning a variety of people's incentives around something that's new and innovative is a really big challenge. So building out prospecting tracks that target to specific personas within an organization and align to their value propositions is a really important first step. Getting buy-in from a variety of different persona types, starting maybe with someone in SDOH and then moving on to someone that owns a P&L in a market, like a plan president or a plan CEO, and then moving into implementation. How are you going to integrate with case management? And so case management leadership. So we've sort of learned as we've gone that it's really important to get the buy-in of a variety of different decision makers and persona types within these big buying organizations. And once you kind of can build that playbook, you see repeatability across these organization types, whether they're really big national payers or smaller regional folks.
So can you talk me through the 5Ds?
Sure. It's been a while since I've used those because that was predominantly related to our older adult population and the direct to consumer model. But yeah, what we found was that a trigger event typically is what causes the need for someone to move physical locations. Death of a spouse is a number one. We saw that a lot, an older adult especially. If they lost a spouse, it was like the need for them to not be lonely, to move into a place that was more suitable for them on their own. Divorce, actually, we saw a lot of people that got divorced in their older years. Now we're seeing that across Medicaid populations for people of all ages as well, being a trigger event for having to move. The need to downsize, maybe someone has too much space, more than they realize. Maybe their kids just went off to live on their own, or maybe a spouse has passed away, so you have the need to downsize. You can't afford where you live anymore. Disaster strikes. You've seen floods, you've seen hurricanes, you've seen earthquakes and wildfires. Nobody is completely immune to disasters that happen all around us. That is a big reason people need to move, and kind of a big trigger event that we've seen over the years. And then what was the last one? Death, divorce, downsizing, disaster, and disability. Like if you have a disability that's that you're declining, and so you have mobility needs that change, or accessibility needs that change. If you recently have a new disability that requires your living situation to change. So those are kind of the 5Ds that we've articulated. And even having just started in older adults, we've realized that those really apply to all people across the age spectrum. This is the reason that people are kind of burdened by housing instability and all of the negative things that come alongside that.
Yeah, I think I've kind of come up against that question myself when it comes to any kind of like operationalizing social care in the hospital settings, because just like the health system in general tends to be those moments, brings about a lot of those moments where the change in life, the change in condition, functioning, mobility, or facing death itself can kind of create those moments of like, I need to change. That realization that where things are heading and how my lifestyle or how my life is currently looking, it's not matching up to who I perceive myself to be or my value system. So the healthcare system definitely creates it already has those prime moments, I think, it's ripe with opportunity to create a positive trajectory toward better health outcomes, just being what it is, because again, you have those moments where you kind of like the inside meets the outside. And so I guess, have you found a lot of success there in kind of creating interventions that are anchored to those real world life disruptions, and as opposed to like chronic conditions?
Yeah, it's a great question. And the answer is simply we have. And the reason that we have is because I think of our unique method of integrating with health plans themselves. What we've seen is that health plans that manage very vulnerable populations, they're typically assigning a case manager, a skilled case manager to help manage a lot of the chronic conditions and a lot of the challenges that those types of people face. And as a result, in many and most of the interactions that these case management folks have with members themselves, housing comes up as an issue, and maybe more than 50% of the time that we see. When you have a lot of other things going on in your life, housing is usually a very core component to one of those kind of exacerbators of poor outcomes. And so housing issues come up with case management, and case management bubbles them up to us, because a lot of times, or most times, case managers don't have the resources or the capacity to handle with how these really complex housing issues that are very challenging to manage when you're managing 999 other people who have multiple chronic conditions and lots of other stuff going on in their lives. And so we sort of come in and say, hey, we're a housing easy button. If and when we know that housing is going to come up in your conversations, in your normal cadence with a vulnerable member, kick them over to us. We're the housing easy button. Send them over to us, and we're going to take care of it from A to Z. We're not just going to screen them and then guide them to a local CBO. We're going to screen them. We're going to hold their hand throughout the process until they are stabilized, and everyone has confirmed that they're stabilized in an appropriate setting. And that does a few things. Number one, it gives peace of mind to our health plan partners that the loop is actually being closed on the intervention. That's something that they don't see a lot, especially on complex interventions like housing. Number two, we're reporting on this data, on all the interaction, all the engagement that we have. So not only can we claim to be a housing first member engagement tool or program, we are that, and we're showing how we are that. And I think that goes along to reinforce the kind of the model, this care management integration model. This is an arm of care management. It's not a replacement of, and it's not kind of a side to, it's a part of it, an extension of it. And I think that does a lot to kind of reinforce the importance of housing as an intervention. And then, of course, the decision making around all that data. I think health plans have historically not had a great ability to make smart and sound financial decisions based on previous social programs. And I think part of that is that they haven't had a unified and clear and articulate data story to tell around those interventions. We provide that. And so as a result, they're able to very clearly and quickly make decisions on, number one, the efficacy of these programs and the efficacy of the cost reduction around them, and the kind of the justification for expanding these programs, both regionally and within a state and nationally.
When you first approach these members, how do you build that trust from the beginning?
That's a great question, and trust is absolutely foundational to everything that we do and to our ability to actually help and move the needle for people. We build it by actually doing. Instead of just saying that we're going to plug someone into a local organization, we walk them to figuratively, we walk them to the local organization. We get it done for them. If paperwork needs to be filled out for them, we fill out the paperwork. If a driver's license appointment at the DMV needs to be scheduled for them, we make it easy and we do that for them. And our technology helps us be efficient when we do that for them. So we can do it at scale. But we go that extra mile so that we can build that trust and build it really quickly. And I say it all the time, so many social programs and programs that try and get members to engage in their health and in their community, they don't work because that trust is not built. And so when we're talking about something so important as housing with a member, almost like a Pandora's box opens up as a result of that. If someone's sleeping in their car tonight and their case manager calls them about going to see their primary care physician for an annual wellness visit, they're hanging up on that case manager. They don't care about going to make that annual wellness appointment if they don't know if they're sleeping in a Walmart parking lot tonight. However, if you can help them get on the journey towards housing stability by assisting them in getting a driver's license or assisting them in getting a social security number so that they can apply to an apartment because they've never applied to an apartment before and they don't know how, even though they have income, they don't know if they're going to get accepted because they have a criminal background. If you can help them on that journey, get on that path and hold their hand through completion, then once they're settled and you ask them to go, hey, your new apartment is actually 4 blocks away from a primary care doctor that's covered by your Medicaid plan. Why don't we get you scheduled? 99 times out of 100, they'll do that. And so we're seeing the downstream effects of stable housing on all of these other really important interventions that we know for a fact will decrease healthcare costs down the road, like primary care visits, like ensuring proper nutrition through food programs, like ensuring regular transportation to things like doctor's appointments or follow-up visits or whatever it might be. And so those are really important elements of kind of ensuring long-term health and stability, but it can't be done unless you start with housing. And that's where we're really building the trust.
Before we get back to Jake and why housing is healthcare, I need to take a moment for something urgent. Now, if you're listening to this, you're probably someone who's held the line when no one else would. Someone who believes care still matters even when systems forget. Right now, HR 1, or the One Beautiful Bill Act as it's called, is working its way through the Senate. And if passed, it would gut Medicaid, strip health coverage from millions, and destabilize the already fragile care systems across the country. And even if it doesn't pass in full, the message from this administration is very clear. Medicaid is on the chopping block. Social supports like SNAP and broadband are considered optional. And CMS is not accounting for sequestration in Medicare Advantage rates. This means that every contract, care model, and strategy built on federal stability is already out of date. If you're leading a program that's already on razor-thin margins, I built something to help you stay ahead. My HR1 Margin Erosion Toolkit is a strategic weapon for people who lead with both heart and math. It helps you model your projected financial fallout, translate your mission into margin, and walk into your budget meetings with answers. If you lead a care program, a nonprofit, or anything funded by Medicaid, you can't afford to be unprepared for what's ahead. Grab the toolkit now. The link's in the show notes. But if nothing else, call your senator. I posted earlier this week, and some people mentioned the 5 Calls app. I personally just used Google to find the numbers, and that worked fine. But however you do, just make the call, because silence doesn't protect people, but strategy does.
So do you get a lot of resistance from older adults that say that they want to age in place, or that they want to, they don't want to go, maybe they think that you're going to send them to like a sniff or something like that?
It's a great question. Only a small percentage today. Most of the people that we work with are kind of the general Medicaid population, so they're not necessarily older adults. I'd say 20% of the people that we work with in the Medicaid world are dual eligible, so older and a lower income. But of the percentage of population that we do work with that are older adults, typically what happens is by the time they're coming to us, they recognize the need for a move, either because they physically or financially or mentally can't stay in the place that they're in. And so they're, by the time they reach us, they're really open to that. Our goal is to try and get people earlier in this journey towards stability. And so if you can capture them earlier, there might be more of an education process along the way. But to date, we haven't seen that. Today, we've seen, most people are ready to make a move for the betterment of their health and their lives. And we're here to offer that helping hand.
And you're operating in over 42 states right now?
Yeah, so our network of apartments, that's sort of a real estate network tailored to a medical or healthcare population, is operational in 42 markets. We operate kind of with health plan partners in a dozen states or more. So not all of those states, but we're ready to operate in all of those states. So yeah, we're national in scale now, and now we're seeing, kind of the doubling down in many of the biggest markets.
So was there any moment when you kind of realized that you need distribution and payer alignment to move from just an idea to a total industry transformation like this?
No, I think that distribution is very hard in healthcare. I think that's the hardest part, right? Like you can have a great product or a great idea or a great program, but if you don't know how to get it to people and you don't know how to get it to people efficiently and at scale, it's really hard to make the impact that you really believe you can make. And so we cut our teeth with a lot of smaller payers who we got consistent pushback from them that, it was hard to find distribution. It was hard to find payment mechanisms. We don't know how we're going to pay for this. We love the program, but we have to help find dollars to get it done. And then once we started talking to really the biggest payers in the country, there was a lot more flexibility for rolling their sleeves up with us and testing some of these things. So kind of opposite to what you would think. You would think that the biggest players would be the last adopters or the latest adopters, but in fact, we found the best kind of initial or early adopters were the biggest payers in the country, because they have kind of a bent towards innovation and they have some extra money to play with to see if and what kind of programs might actually move the needle.
So I guess that biggest takeaway there is designing your model with channels built in.
Yeah. So from the very beginning, even when we started the direct to consumer business, we said, ultimately, we want to build a payer channel. We want to understand how we're going to sell to Medicare Advantage and to Medicaid managed care organizations. And we want to make sure that from day one, this is a scalable, repeatable model that solves a problem that's a very local problem. Real estate's a local problem. There's different availabilities in every market. There's different nuances to all the real estate availability in the stock in every market. And certainly there's differences to the kind of the service infrastructure that surrounds that real estate in every market. And so we said, okay, how can we from day one build this network that can scale nationally, that can be sort of modified at a local level so that we can understand the nuances associated with each market. And so that's what we did. We always had kind of the end in sight, where we said, okay, payers are going to be the body that cares about this, and members are going to be the ultimate recipients of this work. And so, like, how can we kind of reverse engineer from that? And that's what we did from day one.
With like CMS pulling back on equity measures, threatening social determinants of health, cutting Medicaid, do you see the need for this kind of infrastructure becoming more in demand, or do you see it kind of being threatened?
Yeah, it's a great question. We're seeing a pull from the market, and we're also seeing the kind of this movement towards privatization. We think that, maybe a movement not away from CBOs, but a lessening emphasis on CBOs to do a lot of this heavy lifting, and more an emphasis on private organizations that can drive value for both the taxpayer and for the member and for the private payer. These are interesting. They're interesting times, no doubt, but we're seeing an acceleration in the need for our services because of a pullback in a lot of the government-funded, grant-based housing type of programs that we see at the local level in all these places. And I think from a social determinant standpoint, there's no slowing that down. That has been in the movement in the making for a long time. There's no choice. Society has no choice, and if the government has half a brain cell to work together, they will understand that social determinants is our only way out of the crisis of the multitude of crises that we face. You've got 12,000 people a day turning 65 in the United States with not enough clinicians, not enough providers, not enough medical infrastructure to actually care for people once they're sick. So if we don't go upstream in this in the world of prevention, we are never going to be able to care for all these people. And so, but either by necessity or by intellect, something's going to give here. And we think that we're really positioned well to ride that wave. Housing being the most core and the most fundamental. If you think about Maslow's hierarchy, shelter is the most kind of core need, fundamental need for a person. So we see an opportunity, a really, really big opportunity to kind of own the entire social determinant space as it relates to payers. And because housing is so key to that, and that's where we start.
So what about the question about attribution?
Great question. Attribution has always been a topic of conversation among social determinant companies, right? It's very hard to understand which social program is actually moving the needle on outcomes. And you can do things that allow you to get clarity on those answers. And what we've done is with our health plan partners, we pull claims data to understand cohort, and we run cohort analyses on lookalike populations that are either served by us or not served by us. So we can really start seeing what moves the needle and which interventions move the needle. There's a way to sift through the noise, and there's a lot of noise. There's a lot of point solutions in the space. There's a lot of SDOH companies claiming to improve outcomes and maybe or maybe not actually improving outcomes. And so we work with our partners really closely to kind of sift through that noise and provide actionable insights on actually how we're moving the needle for them and for members.
Can you name some of those actionable insights?
So reductions to hospitalizations, reductions in hospital length of stays, reduction in falls, medication management that we see improvements upon because of proper housing. If you don't have an address to send your drugs to, how are you going to take your drugs reliably? Maybe you're living in your car, maybe you miss a prescription, or you miss a dosing of your medication because you don't have a permanent address. So when you think about the multitude of things that are sort of tied either directly or indirectly towards your housing situation, you can start really understanding the impact to all those downstream things that may or may not be addressed as a result of improper housing. Even things like nutrition, we run into people that don't have microwaves in their homes, right? How are you heating up a meal? Well, we're not heating up a meal, we're just eating canned food. So like nutrition is impacted by proper housing. And so it's really all tied together. And we make that clear case for health plans and our partners and the actuarial teams at these organizations that are having to make decisions based on these programs. And we help spoon feed all of that into really clear and robust ROI models that are population dependent. So we ensure that our ROI models cater specifically to the types of the populations that we serve specifically. And every program is kind of initiated with that in mind.
So how did you tailor your model to kind of integrate into care management workflows so that it works as like core operating capacity, not as opposed to like something on the side?
In the early days, we thought about how health plans operate, right? And the last thing you want to do is to sell something to them, a program to them that is going to be too challenging to implement, so you get very little utilization. So we said, okay, where are the wedges into a health plan? Well, you can run an outbound engagement and enrollment program, but that's kind of a hard wedge in because nobody answers the phone anymore. And if they don't have a problem, they don't really want to talk to you. And utilization on programs like that are typically very, very low. Whereas if you plug in through case management, case managers have relationships that are already built with a lot of these vulnerable members. They have ongoing dialogue with them. And so as a result, there's kind of an initial trust already built that we are able to ride upon when a referral comes through case management. And it enables us to enroll people into our program at a ridiculous rate. I mean, we have a 97% enrollment rate for referrals that get sent to us through case management. And so when you think about that number and as how it relates to other programs, SDOH types of programs, that's off the charts. And it's off the charts because number one, we believe housing is core to someone's life and well-being, and they're going to talk to someone that can help them with it. And number two, we're riding on the existing trust from that case management team. And so we thought there was a natural way to plug into health plans versus kind of coming over the top with some really heavy lift type of programming that they have trouble implementing.
Is there any kind of like feedback loop that you have between consumers now that ensures that you're kind of responding to their immediate pain points as opposed to kind of like a one-fits-all? solution?
Totally. I mean, every member is handled as an individual. And we do individualized kind of intakes and assessments with our care guides. Our care guides are licensed clinical social workers, so they really understand how to speak with members, how to understand their real situations. And every single member that we touch comes away after the initial interaction with the housing, a detailed and personalized and customized housing plan. So when someone comes to us and maybe they're ready for housing tomorrow, they're ready to be housed. What does that mean? Well, they have an income and they have ID and they know how to apply to an apartment, or they know they could use us to help do that stuff. That's one situation. But we have a lot of situations where someone comes to us and they don't have an income yet, or they have mental instability that needs to get treated. In those cases that are really challenging and people may be a little bit farther away from being housed, our goal is to ensure that we can put them on that path towards housing stability. And that's a journey. And essentially what we aim to do is we provide a kind of a very clear path to getting them towards housing and housing stability. And we do that by creating really customized housing plans for every member that we touch. And that housing plan gets sent also to the health plan themselves, the case management team at the health plan, and it also gets sent to the members so that everyone is held accountable to that plan, post enrollment. And we've seen that really work well. We've seen that people that were seemingly very hard to house get housed really pretty quickly with a very clear and actionable plan and some advocacy and guidance alongside that. Anything's really possible.
So what led you away from something like new construction or things like that, and rather to like things that already exist, like the vacant units and existing benefits, overlooked populations?
It's a great question. In healthcare, we think about it as kind of incremental change can lead to really meaningful impact. And so, yes, there's not enough housing. There's not enough affordable housing. New housing needs to be built. Well, what does that mean? It means zoning laws need to change, and it means local state governments need to need to vote on these zoning laws, and buildings need to be built, and construction loans need to be had. There's a lot of complexity. So when you talk to a mother of 3 kids that's living in her car because she doesn't have a house to sleep in tonight, and then you think about all of the things, all the buildings that need to be built to house people like her, you go, there's a big disconnect here. This is not a person that can afford, either physically or financially, to be with her children in a car for the next, let alone night, she shouldn't be, but let alone years that it takes to build that new building. So we said, how can we take the existing infrastructure and just utilize it better? How can we use technology to give better visibility to health plans, to their members, to actually get the most vulnerable people among us, that mother with her 3 children in the car in the Walmart parking lot, how can we get her housed tonight? And so that's the difference that we're making. Not only is it scalable because we don't have to build those buildings and secure those construction loans and change the zoning laws, but it's actionable and it's quick. And I think that speed is what helps us get really good outcomes, and really good outcomes really quickly. You can see savings from speed a lot faster than you can see savings from something that's going to take years.
So is there anything that made you kind of pivot from focusing your attention on older adults and companionship, like you started with Papa, and then kind of made you pivot toward, that single mom living in the car?
The market. Well, essentially what when we started talking to payers, large and small, we started in the older adult space. We started in Medicare Advantage, and every single Medicare Advantage payer who we spoke with was like, this is a really big problem. We're not sure exactly how to find funding for this at the moment. This was back a couple of years ago when Medicare Advantage funding was kind of on the pullback after post-COVID, and when medical utilization was high. But they all said, you should talk to Medicaid. You should talk to Medicaid. You should talk to Medicaid. Because why? Housing is an acute and very tangible problem among low income and those with disabilities. And we had the sense that we can solve the problem, but we didn't know for sure. And then we tried, and it worked really, really well. And so what we said was, wow, we can not just help older adults, but we can help a whole host of people across a very wide spectrum of age and income and ability or disability. And it's kind of been the rest is history.
So so this all kind of started as a personal story, but it sounds like it became this whole platform for like policy, data, systems changed. It would kind of, like, I think if there's like a reoccurring theme, it's more about like the difference between building for one user as opposed to building for the ecosystem.
Yeah, that's right. It did start from a personal story. My grandmother found herself housing insecure at 87 for the first time in her adult life when she moved my grandfather into assisted living. And she's living in this big 2-story house. She couldn't navigate physically. She couldn't afford financially. The family got together and we said, we're going to sell the house. We're going to move her into a rental apartment, use the equity from the house to, let her live for the rest of her life comfortably. And we said, well, there's a lot of people that probably look and act and behave and are in the same kind of physical condition as my grandmother. Only 10% of people ever wind up in traditional senior living. There's a whole world of housing instability among older adults, and many cases that in the older adults that don't have family members that are nearby that can actually assist with this stuff, a lot of this goes unnoticed and unaddressed. And so you have an 87-year-old woman living in a house with stairs that she can't even go up to the second story. And, there's inherent risk in that. There's a risk to her as an individual. There's risk to the system. There's risk to her health insurer. There's risk to the taxpayer. If we could get ahead of that, we said, how can we save the system? All of that. And so, yes, what started from a personal need sort of led us to this problem broadly about housing instability. And we said, oh, it's actually not just about older adults. It's about everyone on Medicaid, and it's about all older adults, and it's not just about financials. And what we saw was similarities across that spectrum, across everybody that had housing instability. There were the 5Ds are sort of what tied them all together. And those were age independent. And we said, okay, well, we can build systems around this. We can build repeatability around this. And we can utilize, just like my grandmother did, we can utilize existing infrastructure to deliver everything that she needs, not more than she needs, but everything that she needs. And everybody wins.
Well, you mentioned earlier that it sounds like the 5Ds is kind of like evolved into something else. Like, is there a different framework that you're using now?
I think that we've just expanded on the 5Ds, and I'm not sure everything starts with a D, so it's not like doesn't fit cleanly into a bow. But, there are definite similarities among all people that are housing unstable. And that's what we're finding. That's where we're finding repeatability in our business. We're seeing patterns among people across population types. And when you see patterns, you can build for scale. And that's really what we're doing, because until you can really build for scale, you can't have the impact that you really want. And so we're intent on making a significant and substantial impact to the world, to the country first, and then to the world. And to do that, you really need to find points of repeatability in order to build kind of scale around those interactions with members, interactions with landlords, interactions with lawyers, whoever it might be that you're interacting with in the ecosystem. Repeatability is really important. AI is actually helping us do a lot of that work. So we're really lucky to be living in a time where you can drive a lot of impact with a lot of efficiency with minimal cost. And, that leads us to a really great business model, but it also leads us to creating better impact, better engagement, better outcomes for members and for their health plan partners, for the people that are responsible or fully at risk for their care.
I just wanted to ask if you found this video insightful. And if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare.
And then is there any other kind of social determinant of health that you're looking at solving soon? Or is it just, are we all in on housing for the foreseeable future?
That's a great question. We're all on housing for the foreseeable future, no question about it. But like I said at the beginning, housing leads us to so many different places. I'd say off the top of my head, a quarter of the interactions that we have have transportation involvement. Another quarter have food that is involved in the process. Housing is fundamental, and it's tied directly or indirectly to every other social determinant. Housing determines how lonely you're going to be. Housing determines how nutritious the food you're going to eat is. Housing determines how your access to healthcare. Housing comes first. And so that's why we're so fully bought in on housing, but it's also why we see this massive opportunity to make a significant impact around all these other social drivers by starting with housing, starting with the trust that housing allows you to build, and then moving into all these other areas.
Definitely. So going back to like that Maslow's hierarchy where you solve for the housing first and then kind of layer on the other interventions on top of that. And I'm sure it facilitates better, interventions from other parts of the healthcare ecosystem as well.
It definitely does. It definitely does. And reporting on that is a really important element of all of this, making sure that payers understand the impact that housing first has on all these other social determinant programs that they may be paying a capitated rate to those vendors. They may be figuring out how to drive utilization on it. So we can come in and we say, hey, we're a housing first company, but we're going to help you drive utilization on this food program, on this transportation program, and on this blah, 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 you name it. What happens? Well, everything just starts working better together once housing is solved.
Okay. So I guess the last takeaway for our audience, anybody that's interested in getting ROI on social determinants of health investments like housing, do you have any advice for them?
Give us a call. We're happy to walk you through it. But I think that generally speaking, I think thematically housing, I think we're seeing it as kind of we're feeling a wave bubble up underneath us. This housing is health wave. And everyone sort of anecdotally understands that. They may not be digging into the details. We can help people dig into the details around it. But housing's not going anywhere. AI is not solving for housing. It's going to help us solve for, housing stability, which is an important thing. But we need to tackle the root causes of the problems that we face as a society if we're going to make sure not to crumble the systems that take care of us today. And so I think that as payers and as program designers and as product people, I think we all need to be thinking about the things where we can make the biggest impact and the most quickly. And it's not going to build big buildings and fund really massive $300 million housing projects that could house 100 people. It's building systems for scale. It's building systems for repeatable scale that are going to impact as many people and move the needle incrementally across massive swaths of the population that will drive savings and positive outcomes and better health and better lives for everybody.
Thank you so much for talking with us today. Thank you for your leadership and everything you're doing for social determinants of health.
Cool. Thank you, Christina. It was really a pleasure.